Okay, so Dr. K here, talking about the next module on bone disorders. And in this module, we're going to discuss certain bone diseases that are very common, and as well discuss the treatments of them. So on this first slide, you'll see that we're going to talk about calcium supplements. Most of the time, we use calcium supplements orally. But sometimes we actually need to use intravenous calcium for more severe conditions such as hypocalcemia. And we'll get into that. Vitamin D supplements, we'll review vitamin D metabolism, how it's made, how we get it into our system. So we'll start with that shortly. Then we'll get into some medications such as what are called SERMs, selective estrogen receptor modulators. These are medications that are used for osteoporosis. And as well, we're going to talk about another group called bisphosphonates. And as well, these are commonly used for osteoporosis. And lastly, we'll discuss a hormone that's naturally produced in the body, but also used as a medication called calcitonin. So this slide is showing you calcium metabolism in the body, and let's just review it so that we have a good understanding of how calcium is kept in very tight parameters. Because low calcium or high calcium will have significant effects on different body parts, okay? And whenever you're thinking of calcium, there's certain organs that should come to mind. So definitely the bones in calcium metabolism, but calcium levels can have effect on the heart, the nervous system, the muscles, they all require calcium. And lastly, blood coagulation uses calcium in some of its reactions. Okay, so whenever you are looking at low or high calcium, it's likely going to have an effect on one of those systems: heart, muscle, nerve, blood coagulation, and bones. Okay, so let's look in the top left corner here, parathyroid gland. Okay, so what does the parathyroid gland respond to? Well, these are four little glands that are located behind the thyroid gland in the neck. Okay, and these two pairs of glands release parathyroid hormone in the setting of low calcium in the blood. Okay, so that's their signal to release PTH, low serum calcium. PTH will go to the kidney, and it's going to increase production of active vitamin D, which is called calcitriol. And we'll talk a bit more about calcitriol in a minute. So PTH tells the kidney to produce more active vitamin D. It also tells the kidney to stop excretion of calcium, start reabsorbing all the calcium, because the main aim of PTH, and therefore the parathyroid glands, is to elevate serum calcium. Okay, so there's the function of PTH. What else does it do? It'll also stimulate bone breakdown. Okay, and by stimulating bone breakdown, that will also increase serum calcium. Okay, now when we look at vitamin D has a number of different ways that it's active in the body. So a lot of vitamin D is actually produced in your skin in an inactive form called cholecalciferol. And you might see that in one of the chapters that you're reading or on a slide somewhere. Cholecalciferol. It's inactive. When it goes from the skin in the setting of sunlight, UV light, that's what activates it in the skin. Or sorry, that's what produces it in the skin. It circulates in the bloodstream, ends up in the liver, and then becomes calcidiol. The liver processes it. And finally, calcidiol in the kidney will become the active form of vitamin D called calcitriol. Now, what does active vitamin D do? Well, it's going to act on the small intestine to increase absorption of calcium that's in your diet. Okay, so it's another way of increasing serum calcium. Calcitriol also works on the bones in combination with PTH to also regulate serum calcium levels. Okay, so all of these effects, the action is to increase serum calcium, right? That's what PTH does, and that's what vitamin D does. And remember, the active form of vitamin D is calcitriol, which is made in the kidney. You can also purchase calcitriol. So you can actually buy the active form of vitamin D. Most of us don't need to purchase calcitriol because if we have functioning kidneys, whichever form of vitamin D you purchase as an oral supplement, it'll get converted by your kidneys to calcitriol. People with renal failure aren't able to do that conversion very effectively, and that's why you'll see chronic renal failure patients on calcitriol directly, because they can't do the conversion by their very weak kidneys. Okay? On a day-to-day basis, where do we get vitamin D? Typically from skin production in the setting of sunlight, unless we're on oral supplements or we're ingesting large amounts of calcium in our diet, such as dairy products, an example, milk, cheeses. In fact, milk is supplemented with vitamin D. Okay, so this next slide on serum calcium homeostasis, very similar to the slide above, just in a slightly different way. So low serum calcium concentrations in the blood will lead to the release of parathyroid hormone, PTH, from those 4 little tiny parathyroid glands behind the thyroid gland. And that's going to lead to release of calcium from the bone. That's what PTH does. So that's going to increase serum calcium. It's going to accelerate vitamin D production, the active vitamin D called calcitriol in the kidney. And it's also going to stop calcium loss in the urine. It's going to stimulate reabsorption of calcium. And finally, the active vitamin D that's been produced in the kidney will increase calcium absorption in the gastrointestinal tract. So all of these effects with the sole aim of increasing serum calcium. So when we're talking about vitamin D, its main effect is to increase serum calcium by increasing gastrointestinal absorption of calcium. Okay, so and once serum calcium is at a proper level, is maintained in a very tight parameter, then that will reduce production and release of parathyroid hormone from the parathyroids. Right? So the parathyroid hormone is only released when serum calcium starts to drop. Okay? So if you actually don't have active vitamin D, such as in renal disease, so say you have really weak kidneys and you're unable to activate the vitamin D that's coming from your dietary sources and your skin, well, what's going to happen? You're not going to be able to absorb vitamin D from your gastrointestinal tract. Your serum calcium is going to drop. That's going to lead to release of parathyroid hormone from those parathyroid glands and bone breakdown. And that is why patients with chronic renal disease can end up with bone disease and osteoporosis, because the kidneys are unable to make the vitamin D. Serum calcium drops, which stimulates parathyroid hormone release. And what does parathyroid hormone do? It causes the release of calcium from your bones, finally leading to demineralization of the bones, meaning weakening of the bones and less calcium in the bones. Okay, so renal failure patients often have bone disease such as osteoporosis because of their inability to make vitamin D. Okay, so this will start to make some sense. Regulation of calcium balance, as I mentioned, very important process, right? Maintaining calcium serum levels is extremely important to many parts of the body: muscle, nerves, heart, coagulation system, and bones. So the parathyroid hormone we've spoken about, it comes from those tiny little parathyroid glands behind the thyroid. And remember, when you have a thyroidectomy, so removal of your thyroid gland, say for thyroid cancer, there's always a risk that that the surgeon can remove the parathyroid glands. And what's that going to result in? Hypocalcemia, right? You won't be able to maintain serum calcium levels because you're lacking PTH. Okay, so you will be on lifelong calcium because you're lacking your parathyroid hormones. Okay, so what are the cells in the bone that break down the bone matrix to release calcium and phosphate into the bloodstream? Well, those are osteoclasts. What are the cells responsible for building bone and increasing the bone matrix? Those are osteoblasts, right? And they'll use calcium and phosphate to build bone. Calcitonin, that's a hormone released by the thyroid gland, and it acts on the bones to inhibit osteoclasts. And by inhibiting osteoclasts, it can be used as a medication in osteoporosis to stop the breakdown of bones, right? So, and that's where we'll talk about later the medication calcitonin. But in the body, calcitonin is released by the thyroid, and it's involved in controlling the metabolism of calcium. And how does it do that? It stops the breakdown of bones by inhibiting the osteoclasts. Now, when you have your thyroid gland removed, do you need to be on calcitonin replacement? No. There's enough of the other hormones and regulation taking place that patients don't typically need to go on calcitonin replacement when they have a thyroidectomy, removal of the thyroid gland. Okay, just continuing along with calcium homeostasis a bit. So to maintain homeostasis, you do need proper intake of dietary calcium, and typically that amount is 1,000 to 1,200 milligrams per day for an adult. Okay. Vitamin D, so the active form of vitamin D is required to absorb the dietary calcium from the small intestine. Okay, and that active form of vitamin D, calcitriol. Okay, so whether it was activated in the kidney or you took it as a medication, you need the active form of vitamin D. So it's interesting that we call vitamin D a vitamin, because in actual fact, it's made in your skin in an inactive form and activated by your kidneys to become calcitriol. So vitamins are usually substances that are required by the body for metabolism and to run other processes in the body, but the body is unable to make. That's what a vitamin is. But we still call vitamin D a vitamin, even though the body is able to produce it in the skin and convert it to its active form. So it's kind of a topic of discussion whether it's really a vitamin or not, but we still call it vitamin D. Normal serum calcium levels, 9 to 10.5 milligrams per deciliter. That's where the body wants calcium homeostasis to remain in the serum, right? 9 to 10.5. Okay, so just showing you the bone remodeling cycle, and it's incredible how fast bones remodel. So bones that you had years ago have been completely resorbed, meaning broken down, and formed. Right? So there's this constant cycle of bone formation, bone breakdown. And where is most of the calcium in your body? In your bones, right? Plus 97 or 98% of your body calcium is stored in your bones. So the body has a fantastic storage of calcium, and it can access it to maintain its serum calcium levels through this process that we're looking at. So at the top, going clockwise, we'll just see a resting bone surface. The osteoclasts can resorb the bone matrix, leading to increased calcium in the bloodstream. Okay. And then on the other side, as we go clockwise, there's osteoblasts that are actively forming bone. And then the whole cycle just continues, right? So there's always some breakdown, there's always some production of new bone, okay, taking place all the time in the body. Okay, so let's talk about hypercalcemia. What kind of conditions would cause hypercalcemia, high serum calcium? So what about if you had a tumor of your parathyroid gland? So a PTH producing tumor that we would call a adenoma. So a parathyroid adenoma. Is it malignant? No. Does it produce parathyroid hormone? Yes. And that would cause breakdown of bone, increased serum calcium, increased active vitamin D, increased absorption of calcium from the gastrointestinal tract, leading to elevated calcium levels in the serum, hypercalcemia. Okay, so a parathyroid adenoma could definitely cause hypercalcemia. What else can cause hypercalcemia? What about if you have bone breakdown from a cancer? So you have a cancer that's in your bones that's actively destroying the bones, and releasing calcium into the bloodstream. Well, that would lead to hypercalcemia as well, okay? Because of this unregulated cancer that's destroying the bone matrix. So those are examples of where you can run into trouble with hypercalcemia. So what are the symptoms of hypercalcemia? Well, if you look on the left there, there's a bit of a mnemonic. I'm not a huge fan of mnemonic because it means I just have to memorize something. If I understand it, it just sticks with me better. But everyone's different. It's totally fine to have mnemonics to trigger your memory. But high serum calcium, well, stones. So kidney stones, you're going to produce more kidney stones because most kidney stones that are produced are calcium kidney stones. So high serum calcium will lead to stones. Bones, that's referring to painful bones because often you will either have bone breakdown by a parathyroid adenoma or a cancer in the bones that's also destroying the bones and leading to hypercalcemia. So painful bones. Groans is talking about abdominal groans. Why? Because high serum calcium leads to abdominal pain and nausea. So abdominal groans. And lastly, psychiatric moans. That's referring to the increased calcium levels causing changes in the nervous system and leading to potential psychiatric symptoms. Okay, so kidney stones, painful bones, abdominal groans, and psychiatric moans. Okay, so there's a bit of a way to remember hypercalcemia. Image on the right is just showing you that the parathyroids live right on the back side of the thyroid gland in the neck. Okay, so let's talk about hypocalcemia symptoms. But before we do that, let's talk about what can lead to hypocalcemia. Okay, so I mean, if you have severely reduced calcium in your diet, could you get hypocalcemia? I suppose after years and years, you potentially could become hypocalcemia. But remember, you have tremendous amounts of calcium storage in your bones. Okay? What about vitamin D deficiency? So whether you have a dietary vitamin D deficiency or a skin vitamin D deficiency, lack of vitamin D is going to reduce absorption of calcium. And that's going to lead to hypocalcemia. Okay? What about chronic renal disease? Well, basically with chronic renal disease, you're not able to activate vitamin D. So without active vitamin D, again, you have reduced calcium absorption from the gastrointestinal tract. What about accidental removal of the parathyroid glands during thyroid surgery? Without your parathyroid glands, you will become hypocalcemic and you will require calcium supplementation for the rest of your life. Okay? So just examples of causes of hypocalcemia. Okay, so let's look at some symptoms of hypocalcemia. And remember, it's going to be nervous system, cardiac symptoms or cardiac arrhythmias, since you need calcium for proper rhythm of the heart, muscle issues, since you need muscle for contraction. You need calcium for muscle contraction. Bones, since if you have a calcium metabolism problem, it's likely taking more and more calcium from your bones. And lastly, the coagulation system, right? Because you need calcium for certain parts of enzymes and clotting factors to work properly. Okay, so what are the symptoms of hypocalcemia? Well, on the left, those are basically all neurological symptoms and signs. So weakness and tetany. So tetany is really severe muscular spasms. Okay, the calcium is so low that your muscles are now going into severe spasms. Positive Trousseau sign, or this is a different one, Chvostek's sign. Those are signs that we can look for in the setting, or if we suspect low calcium in the serum. And the first one, Trousseau sign, is really when we pump up a blood pressure cuff on the arm, and your hand and your wrist goes into what we call carpopedal spasm, severe flexion of the wrist with pumping up the sphygmometer, or the blood pressure cuff. Why does that happen? Well, you're irritating the nerve that goes down the arm, right? And with hypocalcemia, nerves are very twitchy and irritable. So this is just showing you how irritable it is that when you pump up the cuff, the whole hand goes into this carpopedal spasm. Okay, what about Chvostek sign? Well, that's when you're tapping on the side of the cheek or on the side of the face, where there's a nerve coming down called the facial nerve. And when you tap there and there's contraction of the facial muscle, so twitching of the facial muscle, that's also indicating potential hypocalcemia, because the nerve is irritable, and when you tap on it, it fires off a signal. Okay, so just signs of potential hypocalcemia. Laryngeal stridor, that can have issues with swallowing and voice, because that's what your larynx does. And that is, again, muscles and nerves in the larynx. Dysphagia, difficulty swallowing, again, because you need the nervous system and the muscles of the esophagus to swallow properly. Tingling around the mouth, tingling of the extremities, such as your fingers, very common with hypocalcemia. And definitely if someone comes in and says, you know, I have tingling all around my mouth and my fingers feel all numb, we'll definitely check a serum calcium level. On the other side of the slide, just more symptoms or signs. So convulsions, meaning seizures. So that's the extreme neurological manifestation of hypocalcemia. The whole brain is now irritable, and it's leading to seizure activity, convulsions. Arrhythmias, so cardiac conduction needs proper calcium levels. So it can lead to cardiac arrhythmias, so abnormal heartbeats and conduction in the heart. Tetany, That's the muscles, right? So severe muscle spasms from hypocalcemia that we call tetany. Spasms and stridor, we spoke about, muscular spasms. Stridor is difficulty in your airway, partly due to the vocal cords that aren't functioning properly, and the muscles are irritable and twitchy, and so are the nerves, and it can lead to stridor. Okay, and again, numbness in the fingers we already spoke about. So just think about heart, nervous system, muscles, the bones, because of the low calcium will lead to increased PTH secretion and more bone breakdown. And lastly, the coagulation system. Okay, so where might we need calcium supplements? So oral calcium supplements. Okay, we can talk about IV calcium later, but oral calcium supplements, well, if you're hypocalcemic, like we mentioned earlier, say you're extremely vitamin D deficient, or your kidneys aren't working and you're active vitamin D deficient because you can't make the active form, or you're missing your parathyroid glands and you're hypocalcemic, well, you need calcium replacement. Patients with osteoporosis, that we'll talk about in a bit, are often on daily calcium supplements and vitamin D. Paget's disease, we'll talk about that coming up. Rickets is basically vitamin D deficiency in childhood, leading to very poor calcium levels in the bloodstream, causing weakened bones. Okay? Osteomalacia, that's just in the adults. So it's vitamin D deficiency in adults, leading to soft bones because they don't have enough circulating calcium to maintain strong bones. Lactation and pregnancy, you need more calcium in your diet because you have a fetus that is also requiring calcium for growth, and for breastfeeding you require more calcium because some of it's going into the breast milk for the newborn. In childhood, calcium supplements, often children get enough milk and cheese and calcium in their diet that they don't necessarily need calcium supplements, but as long as they're getting enough calcium in their diet. If they're not, then they would need calcium supplements. Okay? Hypoparathyroidism, we spoke about. If your parathyroid glands aren't working, and by far the most common reason why they're not working is they were removed by accident during thyroid surgery, you would definitely need calcium supplements. Okay, so this prototype slide is really just showing you an assortment of different calcium supplements. So whether it's calcium citrate, calcium carbonate, which is Tums by the way, the last two, calcium chloride and calcium gluconate, are actually intravenous forms of calcium that we use sometimes. Why would we use intravenous calcium? Well, if someone had a severely low serum calcium and say they were having seizures, we could give them intravenous calcium to stop the seizures from the hypocalcemia. Okay, because nothing else will stop the seizures unless we can get their calcium levels back up. Okay, why else do we use calcium in an intravenous form? Well, the other electrolyte that we would use intravenous calcium is potassium. So if someone has hyperkalemia, what do we want to do? Well, we want to try and reduce the potassium level, right? Hyperkalemia, sure, we want to do that. But calcium is highly protective to the heart in the setting of hyperkalemia. So if someone comes in with an elevated potassium level, say of 7 or 7.5, and we know that's potentially deadly to the heart in terms of cardiac arrhythmias, we will immediately give them intravenous calcium, which protects the heart from the high potassium until we can reduce the serum potassium in other ways that we'll talk about on a different slide. Okay, so intravenous calcium, what do we use it for? Low calcium levels leading to seizures or severe hyperkalemia and the patients at risk for cardiac arrhythmias. We will immediately give them intravenous calcium to protect the heart from the high potassium levels. Okay, so really on this slide we're talking about oral calcium supplements. And why would we want to give oral calcium supplements? Well, anybody who's hypocalcemic, right, or has a disease of their parathyroid glands. Typically, they're missing from surgery. That would be the main one. And patients that are requiring a supplement to their dietary calcium. So why don't we talk about some groups that commonly need more calcium. So typically, as I mentioned before, pregnant women do, breastfeeding women do, postmenopausal women. Postmenopausal women are at risk for osteoporosis. So thinning and low density of the bones. And that happens because at menopause, women lose their estrogen. And estrogen is very protective to the bones in terms of maintaining bone health. So with the loss of estrogen comes osteoporosis. So proper intake of calcium supplements and vitamin D supplements are very important in preventing and treating osteoporosis. Okay. So often you're taking calcium supplements and vitamin D supplements at the same time, right? Because it's the vitamin D that gets converted to active vitamin D that allows the calcium to be absorbed through the gastrointestinal system. Okay, so when we're talking about osteoporosis later, or rickets, or osteomalacia, it's going to be calcium and vitamin D supplementation together to make sure that you have proper serum calcium levels. Okay, so there's very few contraindications to calcium. I mean, if you took tremendous amounts of it, could it lead to hypercalcemia? Yeah, definitely. If you had high serum calcium for years, could it lead to kidney stones? Sure. And when we were talking about the slide on hypercalcemia, kidney stones was one of the effects of having a high serum calcium. Okay. Elevated calcium can also lead to cardiac arrhythmias as well. Okay. So typically in the oral form, it would be very, very difficult to become hypercalcemic. Okay. And under the nursing care, just know your proper levels of serum calcium, 9 to 10.5, and that we use intravenous calcium for one of two reasons. Someone who's hyperkalemic to protect the heart, and someone who's so hypocalcemic that they're actually having seizures. And we need to get those calcium levels a bit higher in the bloodstream to stop the seizures. Okay, so I don't think we'll need to spend too much time on this slide. So this is vitamin D metabolism. We've spoken about it as we've gone along here. But vitamin D is synthesized in the skin in the setting of UV light. Vitamin D is actually the base molecule of vitamin D. Like a lot of hormones that you'll hear about later, they're cholesterol based. So the base of vitamin D, the base molecule, is actually cholesterol. So cholesterol isn't all that bad. We need it for a lot of hormone production, and in this case, vitamin D production. So cholecalciferol is made in the skin in the setting of UV light, converted in the liver to calcifediol, and finally the kidneys convert calcifediol to calcitriol, which is the active form of vitamin D, which then increases calcium absorption from the gastrointestinal tract. That's the main function of active vitamin D. Okay, so this slide is just showing you vitamin D synthesis. If you look at the top right corner, sunlight produces cholecalciferol. And then on the right hand side of the liver, you'll see that there is some intake of vitamin D. So certain fishes and meats will have vitamin D, or of course if you take vitamin supplements, that will add to the vitamin D in your system. Okay, and then those inactive forms of vitamin D, whether they're dietary or from the sunlight, will be converted to active vitamin D in the kidney, and that will allow increased calcium absorption in the gastrointestinal system. And what's that going to do? Increased bone mineralization. So if you have more circulating calcium in the blood, your body's going to deposit it into the bone, not only to give structure to the bone, but to also use it as a source of calcium potentially for later. So the biggest source of calcium in your entire body is just the storage in your bone. Okay, so let's talk about vitamin D deficiency in children. And with vitamin D deficiency in children, it will lead to a disease called rickets. And rickets is really inadequate calcium deposition in the bones because you didn't have enough vitamin D to absorb the calcium that was in your diet. So rickets is really poor calcium deposition into the bones, leading to very weak and fragile bones. And if we look at the symptoms, bone fragility and fracturing, so children that have relatively minor injuries that lead to fractures can be a sign of rickets. Atrophy and muscle weakening. Well, we know that vitamin D is responsible for absorbing calcium from the gut. Calcium is needed for proper muscle function. So if we don't have vitamin D, we'll have improper muscle development because of that. Dental problems, well, you need calcium for proper dental growth. And again, without vitamin D, you're not getting proper absorption of calcium. Growth retardation will come again from inadequate calcium to grow the bones. Okay. Enlargement of the spleen and liver, that's a less important one, but we know that low levels of vitamin D can lead to enlarged liver and spleen. It's a bit of a complicated process, and there's no need to get into it because it's not as important as the other ones. Lastly, skeletal deformities. Well, if you have very weak bones, they bend more easily. And you can see in this image here on the right, someone with a femur that's actually bending under their weight bearing. So because the femur is a weight bearing bone, just like the tibia, it's starting to bend because it's so weak, okay? Because the calcium wasn't deposited properly. There was an insufficient amount of calcium that was required to make proper bone matrix. Okay, so skeletal deformities. Okay, so let's look at a prototype for vitamin D, calcitriol. Now remember that if you were to walk down the pharmacy aisle and look at vitamin D supplements, they're not all going to be calcitriol. So calcitriol is the active form of vitamin D. But if you have functioning kidneys, you could actually take many other inactive forms of vitamin D since they'll be activated in the kidney. So patients with renal disease take calcitriol because they're unable to activate the inactive forms of vitamin D. Okay, so what indications for vitamin D as a group? Well, hypocalcemia for sure, right? Since the vitamin D is going to get the calcium into the bloodstream from the gut. Osteomalacia, and rickets. So osteomalacia, okay, that's vitamin D deficiency in adults. Rickets, vitamin D deficiency in children. Osteoporosis, prophylaxis, meaning I want to prevent osteoporosis from occurring. So this would often be a menopausal woman that isn't necessarily osteoporotic yet, but she wants to prevent osteoporosis. Okay, or the active treatment of osteoporosis often involves calcium supplements and vitamin D. So whether you want to prevent it or treat osteoporosis, it often involves calcium supplementation, vitamin D supplementation, and making sure that the person is doing proper weight-bearing exercises, okay, to maintain bone strength. Hypoparathyroidism, again, typically from removal of the thyroid gland. Well, you would need not only calcium supplements, but also vitamin D to get the calcium into the bloodstream. And of course, pregnancy and breastfed infants. So why breastfed infants? Because breast milk doesn't actually have a lot of vitamin D, okay? So we have storage of vitamin D, but as an infant, you will start to run out of your vitamin D storage levels relatively quickly. So breastfed infants typically need a vitamin D supplement for the first 4 to 6 months until they start to have vitamin D supplements in their food, in whatever foods that they're starting to eat. Okay, so not only do breastfed infants need iron supplements, because there's relatively little iron in breast milk, there's also relatively little vitamin D. Okay, so what do all of these vitamin D supplements do? Promote calcium absorption from the small intestine. Okay, and the encouraging of the liberation of calcium from the bone to the blood, that one can be a bit confusing because vitamin D's main function is in the gastrointestinal tract. In the bone, it's really parathyroid hormone that's responsible for releasing calcium into the bloodstream. So vitamin D doesn't have a direct role of calcium breakdown in the bone. It can promote bone production. It just depends on what the serum calcium level is doing and what the parathyroid hormone is doing. Okay, so, and that's why patients with osteoporosis take vitamin D, not to help liberate calcium from the bone, but in combination with calcium, vitamin D will help lay down new bone and put calcium into the bone. Okay, so think of the main role of vitamin D as absorbing calcium from the gastrointestinal tract. Okay. The adverse effects I won't get into too much. It's really well tolerated. These effects would be in massive doses of vitamin D, arrhythmias, pancreatitis. We won't get into that. Contraindications, well, definitely if you were hypercalcemic or if you had too much vitamin D to begin with, that would be a reason not to take more vitamin D. And so just remember the main role is to get calcium into the serum from the gastrointestinal tract. Okay. And one last thing I want you to remember for calcitriol in particular is this is the form that we give chronic renal failure patients because it's already the active form. And what are chronic renal failure patients doing if they don't have vitamin D? Well, they're basically not absorbing calcium because their kidneys are very weak. They're not making calcitriol. Okay, so they're not absorbing calcium. By not absorbing calcium, you're stimulating parathyroid hormone to be released and to actively break down bone, which you don't want to have happen, because chronic renal failure patients will now run into all kinds of bone disorders such as osteoporosis purely for the fact that they're vitamin D deficient. So often you'll see chronic renal failure patients on calcitriol to increase serum calcium levels, to stop PTH from being released, and stop the bone breakdown. Okay? Okay, so let's move on and talk about some conditions of the bone. And osteoporosis we'll spend the most time on. Here we'll just briefly mention it, then talk about rickets and osteomalacia and a condition called Paget's disease. And then we'll come back and talk about drugs that are really aimed at by far the most common condition called osteoporosis. So osteoporosis is really a thinning of the bone. It's a loss of bone matrix. And bone is basically made up of calcium and phosphate. And with osteoporosis, you're losing calcium and phosphate in the bony matrix, which is leading to a weakened bone. And we'll talk about conditions that lead to osteoporosis. But by far the most common is postmenopausal women. There's other ones as well, such as chronic steroid use, early menopause. Say, for example, a younger female, say in her 30s, had a disease where the ovaries were removed and estrogen replacement wasn't taken. Well, she'll basically be postmenopausal as well. She won't have any estrogen in her system, and this will lead to osteoporosis. Okay, so osteoporosis we can diagnose with what's called a bone density scan, and they're done very frequently, especially around the age of 50, to see if if a woman is at risk for osteoporosis. Now, before becoming osteoporotic, you can be osteopenic, meaning the bone scan hasn't quite gotten to the level where the bones are so thin that it's diagnosing osteoporosis, but it's on the way, and we call that osteopenia, meaning low bone density, but not quite osteoporosis yet. So as I mentioned on the slide before this one, it's really a demineralization of the bone. The osteoclasts are breaking down the bone faster than the osteoblasts are producing it. And this typically starts in your 30s. Your peak bone mass is in your 30s, especially for females. And then gradually over time, the bones demineralize. So prevention of osteoporosis is very important, since reversing osteoporosis can be very difficult, even with calcium, vitamin D, and some of the drugs that we'll talk about. So it's definitely more common in women than men. What does it affect typically? It usually affects the vertebral column, leading to compression fractures of the vertebral column, which can then lead to kyphosis, which is that hunched over appearance that you might see in older women. It often affects the hips, which leads to hip fractures with a fall, and wrist, which leads to wrist fractures, which is very, very common with minor falls in older women. Okay, and as I mentioned, the gold standard for diagnosing osteoporosis is a bone density scan. And here we see vertebral fractures. Some of these can actually be spontaneous, meaning that it took really no injury for them to occur. It's just that the vertebral column is a weight-bearing structure, and as the bones weaken, they gradually have fractures in them. Now, if a postmenopausal woman who's osteoporotic had a fall, say on her bottom, she could easily have vertebral compression fractures. And you can see the arrows that are showing the squashed vertebral areas. And this is often due to osteoporosis. Okay, so here's an X-ray image showing a right hip fracture. So hip fractures are extremely common in women and in men, but by far more common in women because of their risk for osteoporosis. Okay, so let's just spend a bit of time on rickets and osteomalacia. As I mentioned before, rickets is really a vitamin D deficiency in children before the growth plate or the epiphyseal plate has fused, right? So the epiphyseal plate or the epiphysis is where the long bones grow. They're called your growth plates, and they're typically at the ends of the long bones. And vitamin D is very important to absorb calcium to allow for proper bone expansion. So with rickets, you'll get growth retardation because of calcium deficiency. Okay, and a very soft and weak bone matrix because the osteoblasts didn't have the calcium required to deposit into the bone for proper strength. Osteomalacia is really the adult form of it. So the hypocalcemia that is caused by the vitamin D deficiency again leads to poor mineralization. Mineralization just means the calcium and the phosphate that's being put down on the bone matrix. And it leads to a softening of the bone in a condition that we call osteomalacia. And here's an image of rickets in children. You can see in this image, just to mention, in case you weren't sure where the growth plates are, or the epiphyseal plates, you can see at the top of the femur, there's that dark line. And at the bottom of the femur, there's a dark line. Those are the growth plates. That's where bones grow from. They don't grow from the middle of the bone. They grow from the ends of the bones. And in this image, you're seeing significant bowing of the femur, and in fact, the tibia, the lower leg bone, because of how weak the bone is. And because the child is weight bearing on that bone, it's starting to bend. Okay, so osteomalacia, as I said, it's a softening of the bone. The underlying basic bone structure is there, but the laying down of proper calcium into the bone matrix isn't there any longer because of a vitamin D deficiency as an adult. And this can occur in older adults that have really poor intake of vitamin D, or they don't get out in the sunlight very much. Very premature infants will develop rickets as opposed to osteomalacia. And strict vegetarian diets in adults can lead to osteomalacia because of not only a calcium deficiency in their diet, but also a vitamin D deficiency. Okay, and this image is really just showing you osteomalacia. You can see the bowing of the tibia, right? The lower leg bone, it's starting to bend outwards because of the softening of the bone and the weight bearing on the leg. Okay, and we're almost finished with osteomalacia. Let's just go right to the causes. So again, the structure of the bone is fine. It's that they don't have enough calcium to make the bone strong. Okay, so malnutrition in an adult can lead to this because of poor intake or poor sources of vitamin D rich foods. Inadequate sun exposure, say in an older person, where they're just not producing the inactive form of vitamin D, that will lead to absorption, or that would lead to the active form of vitamin D from the kidney. Okay, so really see vitamin D as the important vitamin to absorb calcium from the gastrointestinal tract. And on the bottom, in terms of causes, you'll see that they mention kidney failure. Okay, so kidney failure is there purely because the kidney is responsible for making the active form of vitamin D. And if you don't have that, you have improper serum calcium that activates parathyroid hormone to start breaking down your storages of calcium in your bone to maintain serum calcium. And because of that, you can develop osteoporosis or osteomalacia, a softening of the bones. Okay, so these three images are just showing you the differences of normal bone versus osteoporotic bone, which is just thin and brittle because there's just not enough calcium phosphate that's been deposited. And typically osteoporosis is from the osteoblasts the osteoclasts breaking down the bone faster than the osteoblasts are producing it. And again, I'll remind you, postmenopausal women are at highest risk for this. And chronic cortisone use, which thins the bone, leads to osteoporosis. Inadequate dietary calcium and vitamin D can lead to osteoporosis as well. Okay, so let's go to the next one, osteomalacia. The actual total structure of the bone is normal, but it's become weakened because of demineralization, because of vitamin D deficiency. Okay, so it's more of a softening of the bone. So Paget's disease is a disease of older people, and it's a bit of an interesting disease. Now, I don't want you to think that rickets and osteomalacia and Paget's disease is as common as osteoporosis, because they're definitely not. But really what it is that if you remember the slide that showed you the cycle of bone production and bone breakdown in one of the first few slides of this module, well, Paget's disease is basically an acceleration of that cycle. So a lot of bone growth, a lot of bone breakdown, and it just keeps on cycling it like that very quickly. And it leads to really abnormal bone because it's breaking down and being produced so quickly that it leads to areas that are over calcified and enlarged, and then other areas that are softened. We don't really know the cause of Paget's disease, and a group of medications that we'll talk about called bisphosphonates can be used for Paget's disease to try and slow down that cycle of breakdown and then building and then breakdown and then building. And calcitonin can also be used for this, since it also stops the osteoclast from breaking down the bone. So I'll show you an image of Paget's disease. Okay, so at the top of the skull there, in the left of the image, you'll see this excessive bone production, just very irregular shape. It looks nothing like the right side, which is a normal shape of the skull, and it's because the bone cycle has just accelerated so much that it's making very abnormal soft bone, and too much of it in places and too little of it in other places. Okay, so the drugs that we're going to talk about now, I would really consider them for osteoporosis, just because it's by far the most common condition that we're talking about right now. Yes, they can be used in Paget's disease, but really, when we're talking about this group of medication called SERMs and the next one called bisphosphonates, really keep at the top of your mind osteoporosis, okay? And the first thing that I'm going to say is when we're talking about osteoporosis, typically patients are on these medications, or one of these medications that we're going to talk about, and they're on proper calcium and vitamin D supplementation to make sure they have proper serum calcium so that bone can be produced by the osteoblasts. Okay? So what are SERMs? So selective estrogen receptor modulators. So estrogen, as I mentioned before, is a very important hormone in women that maintains bone strength and integrity until menopause, right? And after menopause, when the ovaries have stopped functioning, estrogen levels fall significantly in women. Okay, you still make a bit of estrogen, a tiny bit from your adrenal glands, but the vast majority of estrogen is made from the ovaries. And in the first 5 years after menopause is where women lose a lot of their bone mass because of the lack of estrogen. So these estrogen receptor modulators are meant to stimulate the bone and pretend that they're like estrogen in order to maintain bone mass. Okay, so they can be used in osteoporosis to stop further bone breakdown. Okay, so the interesting thing about these drugs is they act like estrogens in some tissues, and they act like anti-estrogens in other tissues. It just depends on which receptor they land on. Okay, so in the bone, they behave like estrogen, and they prevent bone breakdown. Okay, so that's very beneficial, right? In the liver, in the bloodstream, they thicken the blood. They increase, these drugs can increase the amounts of proteins that are produced in the liver, and that can lead to thickening of the blood. So they have a procoagulant effect. So you'll see that under some of the adverse effects that we're going to talk about, that one of them is going to be DVTs and PEs. Okay. What else do they do? Because they act as estrogen blockers in some tissues, women get menopausal symptoms from these drugs because they're acting as estrogen blockers. Okay, so women have estrogen receptors all over the body. So in the bones, in their tissues, in the blood vessels, in the liver, in the uterus, and depending on how that particular receptor sees this estrogen receptor modulator is how it's going to react in that particular organ. Okay, so good for the bones, not so good for the uterus, not so good for the blood because it can thicken the blood a bit, and not so good for menopausal symptoms because they're blocking those receptors in the tissue and causing menopausal symptoms. Okay, the main one that we're going to talk about today is one called raloxifene, and raloxifene is used for osteoporosis. Okay, tamoxifen that you'll see at the bottom there is used for breast cancer. That's an estrogen blocker in the breast. Okay, so we're just taking advantage of whether it's an estrogen stimulator or estrogen blocker in the particular tissue that we want to treat. Okay, so we're going to talk about raloxifene because it stimulates and protects bone from breaking down. Okay, so continuing with these selective estrogen receptor modulators, raloxifene is the one we're going to talk about here. Tamoxifen you'll get in another module, I think, in the next pharmacology class. So basically these modulators bind to estrogen receptors around the body, and depending on where the estrogen receptor is, meaning is it in the uterus, is it in the breast, is it in the bone, it can have a positive effect, which is an agonist effect, or a negative effect, which is antagonist. Okay? So because it has a positive effect in the bone, we can use it to treat and also prevent osteoporosis. So someone who's at high risk for developing osteoporosis could take raloxifene to stop further breakdown and become overtly osteoporotic. Okay. The interesting thing about this drug is that its action in the breast is antagonist. It blocks estrogen from stimulating the breast. And when you block stimulation of a tissue, you reduce the potential for cancer because the cells aren't dividing as rapidly. So because raloxifene, or more importantly, tamoxifen, blocks the estrogen receptor in the breast, it can be used to try and prevent breast cancer in someone at high risk. Okay, so really, they're just used depending on which tissue we're trying to treat. And since we're talking about bones, raloxifene has the indication for prevention or treatment of osteoporosis. Okay, to try and reduce fractures in osteoporotic women. Okay, so here's the prototype slide for raloxifene. What do we use it for? Osteoporosis. Okay, right? It'll slow down bone breakdown, which will allow the osteoblasts to deposit more calcium phosphate into the bone, increasing the strength of the bone. Can it be used to block the estrogen receptor in the breast? Absolutely. So it could be used to try and prevent breast cancer by blocking the estrogen receptor so that estrogen can't get onto that receptor. Okay? So these selective estrogen receptor modulators are very interesting just because they have this positive effect in some organs and negative effects in other organs that have estrogen receptors. So the adverse effects should make more sense now. There's an increased risk of DVTs and of course PEs. Whenever you have an increased risk of DVT, you automatically have an increased risk of PE, because a PE is basically a broken off piece of a DVT. And why is that? Because this drug acts in a positive way, an agonistic way on the blood vessels, and it thickens the blood. Okay? Why do you get hot flashes? You get hot flashes because this particular drug is blocking estrogen receptors in the tissues in the body, and you get hot flashes because it's almost like it's making you menopausal. So the contraindications, definitely if we're playing with estrogen receptors and blocking them, we would never use this in pregnancy. And of course, anyone who has a history of DVTs or PEs. Now, under nursing considerations, how do we follow someone who's taking this medication for osteoporosis? Well, it would be with bone density scans, and often they're done every 1 to 2 years. Okay? Bone density doesn't change that fast, so it's not like a bone density scan every month would be beneficial. So typically every 1 to 2 years. Okay? Remember, when you're on a medication like this, making sure to have the proper amount of calcium and vitamin D in the bloodstream to allow the osteoblasts to lay down new bone. As well, when you have proper amounts of calcium in the bloodstream, what that does is it prevents parathyroid hormone from being released. And when you prevent parathyroid hormone from being released, it doesn't break down the bone. Okay? So, also in osteoporosis, weight-bearing activities is very important for bone strength, right? So if you have a patient who's in bed for most of the day, the bones aren't going to sense any weight on them, and they're definitely not going to be any strong, very strong. So active weight-bearing activities is really important, along with calcium and vitamin D, in addition to these medications. Okay, so let's move on to another group of medication, called bisphosphonates, and they're definitely the preferred medications for osteoporosis. You'll see patients on these drugs more commonly than, say, the SERMs. Not to say that the SERMs aren't used, but bisphosphonates have been shown to be a bit more effective for osteoporosis. Okay, so what do these drugs do? They suppress osteoclast activity, and by suppressing osteoclast activity, they allow osteoblasts to increase bone density. Okay, the main adverse effects that we'll come to in a minute of bisphosphonates are typically gastrointestinal. Okay, those are the main the most common adverse effects. The most severe adverse effect is a condition called osteonecrosis of the jaw. It's a very strange adverse effect, and we'll show you an image and talk about that in a bit. Okay, so this prototype slide is on alendronate, which is a bisphosphonate. Notice the ending, dronate. So whether it's alendronate or risidronate, which is another common one. Alendronate, the brand name is Fosamax. Risidronate is Actonel. What do these drugs do? Well, the main indication for sure is osteoporosis, just by the very fact of how common it is and how relatively uncommon Paget's disease is. And they act on the osteoclast by not only reducing the number, but the action of the osteoclasts. Okay? And this allows the osteoblasts to have more of an effect and increase bone strength and deposition of calcium and phosphate into the bone, making it stronger bone. Okay? So what are the adverse effects? So we're going to come back to esophagitis. Let's look at gastrointestinal symptoms. So nausea, vomiting, constipation, very, very common in this group. Okay? One of the big ones that we worry about is the first one, esophagitis. The tablet, some of these are often just taken once a week, by the way. The tablet needs to clear the esophagus and get into the stomach. If it doesn't clear the esophagus, it can cause not only inflammation of the esophagus, called esophagitis, it can cause esophageal ulcers. So we tend to really concentrate on information to the patient concerning getting this pill into your stomach. Okay? The other adverse effect is osteonecrosis of the jaw, which is a destruction. So osteo is bone and necrosis is death. So a destruction of a section of the jaw, and it's a very unpredictable adverse effect. Okay, it's not very common, but it's pretty devastating when it does happen. You can also get some mild musculoskeletal symptoms. They tend to resolve on their own, or a patient can be switched to a different bisphosphonate. There's also the potential for some visual disturbances with the bisphosphonates. But if I was going to remember adverse effects, gastrointestinal, including esophagitis, and osteonecrosis of the jaw. Okay? So look at the contraindications. Most of them, well, the first three are all about the esophagus. So dysphagia is difficulty swallowing. So if you have difficulty swallowing, it might not be a good idea to take this pill because it needs to get into your stomach. Esophageal stricture is a narrowing of the esophagus. Well, that could be a problem getting the pill into your stomach. Or really any esophageal disorders can be an issue with taking these medications. So when we're talking about nursing considerations, the most important advice you can give a patient is that you really need to take this pill sitting upright or standing for at least 30 minutes after taking the medication. Okay, so you typically take this with a full glass of water to make sure that it really flushes it into the stomach. And if you were to get heartburn type symptoms, esophageal symptoms, esophageal pain, which typically presents as heartburn, then that would need to be reported, right? Because you're developing esophagitis. Okay. So really, that's the most important side effect to counsel the patient on. Now, the other issue with these medications is that taking them with supplements such as calcium, iron, antacids, all kinds of other supplements is not a good idea because it reduces absorption of the bisphosphonate. So waiting at least 2 hours after taking this medication to take antacids or other supplements. Okay, so really the key is empty stomach with a full glass of water. The other important aspect of this medication is that it's a morning medication, because what happens at night, you take the pill maybe with a glass of water and then you lay down, and that's not part of the way of taking this medication. Okay, so typically it's a morning medication. And remember, calcium, vitamin D, proper weight-bearing exercises is really part of the whole treatment for osteoporosis, not just this medication. Okay, and any kind of gastrointestinal symptoms should really be reported, like especially anything to do with the esophagus, difficulty getting the pill down, worsening heartburn. That should be reported because it may need the medication may need to be stopped. Okay, so if you miss a dose, just wait until the next day to take your dose. You don't need to take it in the evening or to double up the next day. This is a long-term medication for years and years. So missing a dose, not that it's recommended, but it wouldn't be recommended to take it in the evening because you forgot your morning dose. Okay, so this is just showing you the action of bisphosphonates in the bone, right? So inhibition of osteoclast activity and also reducing osteoclasts through apoptosis, right? Which is basically cell programmed death. Unlike necrosis, which is abnormal cell death. Okay, apoptosis is a natural part of cellular of a cell's lifespan, and apoptosis is programmed death. And here's an unfortunate person that developed osteonecrosis of the jaw. Okay, Somewhat unpredictable from the use of bisphosphonates. Some patients that have had significant dental surgery or jaw surgery are at more risk, but in general, this is a relatively uncommon adverse effect, but of course it's mentioned because of its severity. Okay, so almost at the end of this module, the last medication that we'll talk about is calcitonin, and we actually obtain calcitonin from salmon, so salmon calcitonin. It actually comes as a nasal spray for use in osteoporosis, and that would be the main reason for using it, right? So not as effective as the bisphosphonates, can still be used in the treatment of osteoporosis, not for the prevention so much of osteoporosis. Now, what else can we use it for? Well, if someone has hypercalcemia, since calcitonin inhibits osteoclast activity, it'll lower serum calcium. So if you have high serum calcium, such as in a parathyroid adenoma, we could use calcitonin to reduce the level of calcium in the bloodstream. So in general, though, the most common reason for using it would be osteoporosis, to stop the osteoclasts from breaking down the bone. The last one I saw there is bone cancers, and sometimes bone cancers release tremendous amounts of calcium into the bloodstream because they're breaking down the bone, and that would be another reason where we could use calcitonin to stop the osteoclasts from breaking down the bone and reducing serum calcium. Okay. Main adverse effect, really just nasal irritation. So we typically ask patients to alternate nostrils when taking this medication as a nasal spray for osteoporosis. So under nursing considerations, we mentioned that calcitonin can be used intranasally for osteoporosis. It can also be used subcutaneously. So a subcutaneous injection. I don't see it on this slide, but that would be another way of administering calcitonin. Intravenous calcitonin would really be reserved for someone with elevated serum calcium levels, where we really wanted to get it down fast. Okay, so I would say intranasal and subcutaneous would be the most important or the most common routes of delivery. Monitoring for hypocalcemia, sure. Calcitonin is going to inhibit the osteoclasts, so it's going to drop serum calcium levels potentially. If it's being used for osteoporosis, monitoring bone density scans, typically annually or every 2 years. And definitely, like the other medications for osteoporosis, encouraging diets that are high in calcium and vitamin D. Now, I didn't really mention contraindications because there really isn't any. I mean, lithium is a pretty esoteric contraindication for this, so I wouldn't spend too much time memorizing that. Just what I would remember is calcitonin as a drug comes from fish. So if you had a fish allergy, that would be a consideration to avoid calcitonin because of the allergy. Okay, so calcitonin, again, this is the last slide actually. So calcitonin, where does it come from naturally? It comes from the thyroid gland, but we take advantage of it as a drug to treat osteoporosis. Okay, where does it act? Well, it's going to block the bones from breaking down calcium. right? So that's the advantage in osteoporosis. Okay, so it will lower serum calcium by that very action of blocking bone breakdown and releasing calcium into the bloodstream. It also acts on the gastrointestinal system and inhibits calcium absorption there. So really the opposite of vitamin D. It'll lower serum calcium that we see on the left there. It inhibits calcium reabsorption in the kidney. So calcitonin is all about lowering serum calcium. And it's all about having these mechanisms of homeostasis, right? So you have parathyroid working to break down some bone to release calcium into the bloodstream. You have vitamin D that's absorbing calcium into the bloodstream from the gastrointestinal tract. You have calcitonin trying to keep serum calcium levels in check by stopping absorption, by stopping the bones from breaking down, and by allowing more excretion of calcium in the kidneys. So it's really just all about calcium metabolism and maintaining homeostasis. Okay, see you at the next module.